Morning, everyone. We're going to give folks just a minute to file into the room, but we'll get started here in just a few moments. All right. Welcome, everyone. This is the third in a series of webinars showcasing partnerships that maximize opt-out HIV screening. Please enter your name, agency, and email into the chat box when you get a moment. And afternoon, my name is Azul Del Grasso. I'm a senior workforce development specialist with the Denver Prevention Training Center here located in Denver, Colorado. And so this webinar, we will discuss how Ventura County has implemented an opt-out HIV testing program in emergency department settings. The goal of the program is to improve early detection of HIV and linkage to care. So this webinar is going to highlight the efforts of Ventura County, who has increased the number of rapid HIV tests done in emergency department settings and increased linkage to care. Again, when you get a moment, please enter your name, agency, and any questions for us in the chat box that you may have. And we're going to have a Q&A session here at the end of this webinar to discuss what's coming up for you. And so we are a SIBA program for high impact prevention and integration, which is funded by the Centers for Disease Control and Prevention, the CDC. And the SIBA funding has four goals. One is to reduce new HIV infections, increase access to care for persons with HIV, improve health outcomes and reduce mortality for persons with HIV, and reduce HIV-related disparities. And this funding accomplishes its goal in four separate components, which you can see here on the screen. One being the National Training Classroom and e-learning, regional technical assistance, which is continuous quality improvement and sustainability for CBOs, and then marketing administrative support for the SIBA provider network. And then finally, SIBA programs seek to address health disparities, social determinants of health, and provide culturally competent and responsive HIV prevention services. And the Denver PTC is part of component two SIBA providers. A little bit more about this group of SIBA providers. We are funded by CDC to provide regional technical assistance. As you can see, there's four regions: the Northeast in teal, South in red, Mideast in yellow, and us, the West, in purple. And we are among the providers of the West for Track A, which is clinical HIV prevention and for persons with HIV. And so in the West, the providers are Denver Prevention Training Center, San Francisco Department of Public Health, and California PTC. So each of us are assigned specific tracks, and each track has specific responsibilities. At the Denver PTC, we are the Track A provider, and we work with organizations conducting HIV clinical testing and preventions for persons with HIV. And our partners at the San Francisco Department of Public Health provide TA to organizations conducting non-clinical HIV testing and prevention for HIV negative persons. And then finally, the California PTC provides TA on integrated HIV activities and structural interventions like condom distribution and syringe support services. And if you want to access and request these free services, there are two ways. If you're directly funded jurisdiction, or organization, you can request at www.cdc.gov/CTS. And if you're not directly funded jurisdiction or organization, you can contact your jurisdictional health department and ask them to submit a request on your behalf. And so a little bit about the Denver Prevention Training Center. We were founded in 1979, and it's our mission to provide innovative training, consultation, information, and to healthcare professionals and their organization. And we use a unique advantage of being a program within a public health institute, the Public Health Institute at Denver Health. And we reside in a large comprehensive healthcare system, Denver Health and Hospital Authority. And so we operate in partnership with the University of Colorado School of Public Health, with whom we share interdisciplinary staff and faculty. And again, our program is supported through a cooperative agreement with the U.S. Centers for Disease Control and Prevention. So before we start a discussion on HIV testing in emergency department settings, some important housekeeping notes. Please note, again, the Q&A will be at the end of the presentation, and we'll try to address all unanswered questions that'll be sent out to attendees. And you will receive a webinar slide set recording and evaluation link by the end of the webinar or within 1 business day. So this webinar will cover 2 key components of opt-out HIV screening in emergency departments. One is list 2 fundamental program components of opt-out HIV testing screening in emergency departments. Explain how to leverage clinical and community partnerships to implement opt-out HIV screening in EDs. And then discuss how to establish HIV testing in EDs. Our presenters today will be myself from the Denver PTC, Jane Ward and Lynn Bartosh of Ventura County Health, and Dr. Catherine Jacobson of the California Department of Public Health, who will be discussing opt-out testing in emergency departments. And I want to give a huge shout out to Lynn Bartosh, who recently retired from Ventura County and is joining us today. So let's discuss the rationale for HIV screening in emergency department settings. We really quickly want to review the national HIV surveillance data from CDC. The number of folks living with HIV per the CDC is 1.2 million. And it's estimated that the new diagnoses is around 30,000. And then the percent of folks living with HIV who don't know is about 15%. And so the percent of people diagnosed with HIV who are virally suppressed is about 65%. And so as we think about how to end the HIV epidemic, emergency departments are often on the front door or entryway into prevention and care services for many communities. And to meet our goals of increasing the number of folks in care, retained in care, and virally suppressed, emergency departments are key in this effort. As you can see, since 2016, the rates of diagnosis are declining. And HIV continues to disproportionately affect gay and bisexual men who are younger and African American Latino. And nearly 330,000 gay and bisexual men have died since the 1980s. And so as you can see on the right-hand side, that African Americans account for nearly half of new HIV diagnoses, and Latinos account for nearly a quarter. So EDs are a common source for care for communities greatly impacted by HIV and BIPOC and other racial ethnic groups within the AED primary care. Those experiencing economic hardships, people experiencing homelessness, people with mental illness and substance use disorder, and or uninsured for those who use EDs as their primary source for care. And so how common is HIV in ED7? So this was a retrospective study conducted in the Memorial Healthcare System in Hollywood, Florida. An HIV test was offered as an opt-out basis to ages 16 years or older, presenting to the ER of the Memorial Regional Hospital between July 2018 and August 2020. And a total number of 105,000, or 53% of patients of the 196,000 ER visits were eligible for HIV testing. 37% completed HIV testing, and of those tested, about 206 patients tested positive, with 26% new infected patients, and 152 were known infected patients who had not disclosed their status. 45 or 60% of 75 patients with known HIV infections were not engaged in HIV care, but were successfully relinked into care after testing and engagement increased from 50% to 80% post-testing. And so this data demonstrates the value of opt-outs in EDs for identifying both newly infected patients and drastically increasing engagement in care. And so in this EDs have a significant role to play in ending the epidemic. And so let's dive into the rationale for HIV screening in Ventura County. And I want to present how to establish HIV screening in ED settings with our subject matter expert today, Dr. Catherine Jacobson. And so, Dr. Jacobson, I'm just going to stop sharing my screen and just ask you a few questions.
Sure, sounds good. So,
great, thank you. Okay. So please describe the background that led to the initiation of opt-out testing and screening sites that you've supervised.
Yeah, and so I'll just start by giving a little bit of a background on myself. Yeah. Prior to coming to CDPH, I worked at the University of Southern California Keck School of Medicine. And back in 2009, I'm an HIV provider for 30 years. And back in 2009, I was fairly frustrated by the fact that many of my patients who were being newly diagnosed as end-stage AIDS patients, and had often been seen in emergency departments or urgent cares, and no one ever thought to test them for HIV, despite the fact that they were coming in with classic signs and symptoms for HIV. And so that really, back then, led me to a desire to try to educate emergency departments about HIV. And I, at the time, linked up with the LA County USC Emergency Department and was originally going to just offer to train their one or two of their providers in the emergency room to do a train the trainer and teach them one of my classic clinical presentations of HIV so that they could educate their emergency room providers. And from there, they at the time were webcasting their grand rounds. And so I thought, well, if they present to their emergency room, it's going to get to many emergency rooms. And so that was really my original impetus to want to implement HIV testing in emergency departments. Well, that presentation originally took almost a year to happen. It took me almost 9 months to identify somebody in the emergency room who was willing to learn about HIV to present it to their colleagues. Then it took us another 6 months to get on the grand rounds presentation. Eventually we did. And in that presentation, and LA County USC Emergency Department is huge. There's roughly 200 nurses and 75 emergency room doctors, plus about 75 emergency room residents. In that presentation, it became clear that there was challenges in doing HIV testing in the emergency room. And so that's really what led us to begin to work on implementing emergency room testing. And a small group of us began meeting together and addressing the barriers one by one to overcome the barriers at LA County USC Emergency Department. It took us 2 years ultimately to do that. And at that point, we were able to implement HIV testing in the emergency room. And literally the first day we implemented, within the first 2 hours of implementation, we identified our first positive patient. And the program really took off from there. And why did I go to Ventura County and implement with Ventura County? Well, in part because they're my colleagues and friends. We had worked together. I did my residency training in Ventura County, so I knew them, and I knew the value and importance of implementing emergency room testing because HIV positive patients are 3 times more likely to visit an emergency room, be a racial minority, and lack insurance than their non-HIV counterparts. And I knew that EDs were a safety net for HIV infected individuals. And because Ventura County bordered on LA County, we knew that a lot of our patients crossed the borders back and forth between the counties. And so anticipated that we were likely going to find a large number of individuals at the Ventura County emergency departments as well. And so I worked with Lynn and Jane. We worked together and implemented first in the 2 county emergency departments in Ventura County, and then gradually extended that to a private emergency department that was serving a large population that tends to work in the fields in Ventura County. Did that answer your question? Or
Absolutely. No, thank you for that background and for that introduction. I think that's wonderful information to know. How would you describe the process of identifying staff, resources, clinical flow, policies, and procedures? It sounds like it took 2 years to implement that. Were those things that were thought about during those 2 years?
Yeah, absolutely. So the number one thing about implementing in any emergency department, and at this point, I've implemented in HIV testing in 7 emergency departments in California, and have been in the process. We've developed a community of practice for emergency departments in California as a whole. But the number one thing is you have to have a champion in the emergency room, someone who sees the value and the importance of doing the testing. For instance, that's what took us so long at LA County USC to implement, is identifying that champion. And initially, the champion we had identified was a little bit reluctant to really come on board about HIV testing, but then they spent a few months in another country where they saw a lot of HIV, and they came back and they're like, okay, we've got to implement this. Now I see all the patients that potentially had HIV and I missed them. So that really first key piece is finding that champion. Similarly, in Ventura County, what we did is we reached out to the medical director of the emergency department. I had a meeting with the medical director to find out if they were supportive of the idea. And if they were supportive, would they be willing to identify a champion from the emergency room? And they identified somebody. And fortunately, in Ventura County, the county supports 2 hospitals. And so that person and all of their emergency room providers work in both of those hospitals. So that champion turned out to be the champion for both of those emergency rooms. And for the 3rd emergency room, it turned out that the champion from that emergency room was actually the spouse of one of the emergency room providers in Ventura County. And the spouse had seen the value of doing this in Ventura County hospitals. And so they were willing to help implement in this 3rd emergency room. As far as flow, to me, the second most important piece is really putting together standard operating procedures where you literally write down step by step how a patient's going to come into the emergency room, when that testing is going to happen, and then who is going to respond to that positive result, and how you're going to make sure that that linkage to care and linkage to the public health department happen. And putting that all in writing as standard operating procedures is a critical piece, because then you can identify when things fall through the crack, where in the steps are things falling through the crack. And in the process, you typically, once you have your champion, you typically are going to have to meet with the laboratory of that hospital to ensure that they have the capacity to do the testing. Then you're going to need to meet with the emergency room providers and explain why emergency room testing is so important. And it's really helpful in that meeting if you have some of the local epidemiology in regards to HIV. And then once you implement, then you have to work with that team and identify where really where things fall through the cracks. Things are not going to go perfect for those first few patients that get diagnosed. So you have to understand and meet with that team on a regular basis. Typically, we would meet weekly initially to iron out the kinks until we got the system down smooth. And then we gradually back down on how frequently we met. And for Ventura County, it was a collaboration between the emergency room champion, Lynn and Jane, and at the time, the director of the HIV STD program at Ventura County, and the ED champion and myself, and we would just meet regularly, and also the lab director of the county lab there, and hash through those issues.
Wonderful. And could you speak, if you can, to integrating that into the medical record system?
Sure. Yeah. So that is another important piece. We had really good data from LA County. We implemented at LA County USC prior to having EMR. It was, prior to EMRs becoming in existence, which is hard to imagine now because it seems like they've been here forever, but we implemented it at the time that we were still using paper charts. And so we were dependent on providers to remember to test for it, to ask patients if they were willing to test for HIV. And it's a very large emergency room. They have 170,000 visits a year. And we were finding that we were testing somewhere between 500 to 700 individuals a month prior to having EMR. Then when we implemented EMR, we put in a pop-up that would remind providers to ask the patient if they were, well, not really ask the patient because it's opt-out testing. So really to let the patients know that we do HIV testing, just like we do a CBC and chemistry panel on patients. And if they didn't tell us they didn't want the test, then we'd go ahead and move forward with doing the test. And so there would be a pop-up window that would ask providers if they wanted an HIV test. If they said, if they didn't respond or said no, it would pop up again 30 seconds later and ask them again if they wanted an HIV test. And we went from 500 to 700 tests a month to 3,500 tests a month. Oh, wow. So you can see that the big impact of adding that pop-up window and using EMR. However, it's different for every emergency department. Not all emergency departments have the ability to add that pop-up window, or some EDs have had so many pop-up windows that it's become obnoxious and they don't want more. So at Ventura County, their emergency departments have a lot of residents that come through. So they have standard lab orders that they use if they're doing a rule out MI or if they're doing a rule out abdominal pain. And so they just added the HIV testing to all of their standard orders. So it was automatic when they ordered those tests that they would get the HIV. And they used the standard opt-out script. We're going to be doing some labs on you today, CBC chemistry panel and HIV. Let us know if you don't want any of those tests. And if patients didn't say they didn't want them, then they would go ahead and order. So that was a slightly different approach where they added it to the standard lab orders at Ventura County. Other ways that emergency departments have done it is they'll put in algorithms and identify folks who haven't had a test in a period of time that are over the age of 18, or sometimes people who have come in with sexually transmitted infection symptomatology. That will also be a trigger. And those individuals will then get a notice to order an HIV test on those individuals if it's not already part of their order form. So different ways to include the EMR, but the EMR makes a big difference on whether or not tests and opt-out testing actually happens.
It sounds like, and in thinking about the resources, when you were at from paper, you were at 800 tests a month. And then when the EMR, you jumped to 3,500 tests a month. What types of resources did you have to consider during that process? And what kind of resources do you think that folks here on the webinar would be interested or should consider when implementing this?
Yeah, those are great questions. So depending on the size of the emergency room, sometimes it's important to actually support that emergency room and hospital with lab techs. So as part of the funding that we received for LA County USC, we actually gave the lab money to hire a lab tech to support the testing. And we did the testing 24/7 in that lab. And so we hired, I believe we ultimately hired 2 lab techs to support the testing in their emergency room. I can't remember if it was 1 or 2, but the lab was happy to support it if we were able to support them. Other things that you need to consider is whether or not you need to hire folks to do the linkage to care piece of it. And so it's really important to have somebody identified on the emergency room side and either the public health side or a clinic, if you have a clinic that's tightly linked to that emergency room, to have individuals who they're responsible for ensuring that from the emergency department information makes it to the clinic or the public health department about the new individuals that have been identified, whether it's newly diagnosed or return to care patients. Really important to ensure that those patients get linked into care. And often you need a navigator or a linkage to care person whose job it is to track that person until they make it to their follow-up appointment. And so considering whether or not you need a lab tech or need to give some support to the lab, and then a linkage to care or patient navigator. At LA County, because we were large enough and we had HIV fellows, we actually used our HIV fellows to go in and see the patients in the emergency room, and then they would work with them to track them until they made it into clinic, and they would follow up with the same HIV fellow, so the patient already had that personal connection with the provider, and so they were more likely to link to care. But ensuring that you've got individuals identified for those roles is super important.
Great, thank you. And it sounds like, with the increase of testing, you're reaching more populations. Could you speak to what populations, and you spoke to it a little bit earlier, but speak to the populations that are being reached with HIV screening in ED settings versus other traditional HIV screening initiatives?
Yeah. So one thing is acute HIV. So this is not necessarily the patient population, but when the Abbott antigen antibody architect machine became available, which would allow you to do HIV testing within 45 minutes in the emergency room, it has the ability to detect acute HIV within 10 to 21 days post-exposure. So one of the things that is different about screening in an emergency department is that you're more likely to be able to pick up acute HIV compared to screening in routine public health screening settings. And in fact, we looked at that across 9 emergency departments across the US and found that 14.5% of individuals that tested positive in an emergency department had acute HIV. If you compare that to routine screening in public health settings, it's typically 2 to 4% will be identified with acute HIV. Why that's so important is because during acute HIV, the viral load is extremely high, usually somewhere around 5 to 10 million. So those individuals' risk of transmitting to other individuals is increased anywhere between 11 and 70%. And so identifying them during acute HIV and getting them on treatment can decrease their risk of transmitting to other individuals. And it's often those individuals with acute HIV that are sort of often at the center of the clusters and networks that that you may identify within your county or your local community. And so identifying those folks and getting them on treatment urgently is really important to prevent those transmission links. As far as who's in the emergency department, I'll just give you data from LA County to just give you a sense. At LA County USC, 65% of individuals that sought care in that emergency room were Hispanic, 15% were Black, and 80% of the individuals in that emergency room had a household income less than $20,000 per year. So you can see that you're going to access those individuals who you often are not going to see in other settings. And, I would often go in and see the patients when they were in the emergency room as well. And I can tell you that typically these individuals come into care in the middle of the night, often 2 or 3 in the morning, typically on a Thursday, Friday, or Saturday night. And that's the only time they're seeking care, and that's their only point of entry into the healthcare system. So it's really a unique and sometimes the only opportunity you have to engage with these individuals, see them, test them. And I'm also a strong proponent of beginning HIV treatment right there in the emergency room at the time that you see them, because it is your only opportunity. I'm not sure if that fully answers your question or not, Azul, but happy to add to that.
That's great, and thank you for that. And I think lastly, I think we would love to know what recommendations, I mean, you've mentioned a lot, but what recommendations do you have for anyone starting to develop an opt-out HIV testing program beyond what you've already shared, or lessons learned, or what might have you done a little bit differently?
Yeah, I think the important thing is to look at your local area, find out which emergency departments. So look at your EPI for your local area. Find out which emergency departments have a catchment area that really catches most of the epidemic in your area. And I would put my focus on those emergency rooms first, because if you focus outside of where the epidemic is, there have been studies that have shown, in some emergency rooms, you won't find very many people, but that's usually because they're not really serving the population that tends to be at most risk. So first, that's how I would pick the emergency room, is based on which populations they're serving and where they fall within your HIV epidemic in your community. Then I would, this is a little bit of what I said before, but I'll just reiterate it. Meet with the medical director, and having a short PowerPoint that really goes through the data and explains why emergency rooms are important can be super helpful in helping medical directors to understand the value of testing in the emergency room. And then once you have buy-in from the medical director, ask them to help you identify somebody in their emergency room. It won't always go that path. Sometimes you'll be aware of an emergency room doctor who seems to have increased interest in HIV. And so sometimes you'll use that person who's probably going to be your champion to help you connect to the medical director and get the medical director's buy-in. Once you have the medical director of the emergency room's buy-in, and you have a champion, whether you get that champion through the medical director or you get to the medical director through your champion, once you have those two, then it's a matter of starting to meet with administration. Sometimes in the hospital will want to weigh in on this, also the lab directors in the hospital, and then determining who your linkage to care program is going to be and where those patients are going to link. If it's a clinic that's associated with the hospital, then you want to meet with the medical director of that clinic. If it's the public health department, then you want to meet with the lead person over the HIV in the public health department, and start to bring that team together and talk through how this is going to roll out. And then the next step, once you kind of have a plan, is to put that plan in writing as standard operating procedures. And for instance, in all of the emergency rooms where we've implemented, the administration and leadership of those emergency rooms want to weigh in on that standard operating procedure. They want to see it, they want to understand it. And so meeting with those administrators and explaining why it's important, and then how you're going to make sure that individuals linked to care is really important to continue to move that process forward. And then I think the final piece of it is really just, once it's implemented, you're not done. Now is when you have to continue to meet with that team and ensure that you identify where barriers are, what the issues are, and address those in real time. Otherwise, folks are going to get upset, and it's going to come back to really negatively impact the program if you don't address those issues in real time and let the team know how you've addressed them. The last is the training of the emergency room. Make sure that you meet with the emergency room providers prior to implementing, explaining why, and then have a follow-up meeting with them a few months later so that they can give you or ask you the questions that they've run into as they've implemented the program, because they will have some issues will surface, and you just want to be available to help address those issues as you're implementing. And I think that's probably enough at this point, Azul, but I'm happy to answer further questions.
Great. No, thank you, for Dr. Jacobson, for sharing your wealth of experience and expertise in that. And we'll have time here at the end for a Q&A. So folks have questions, we will address those after our next presenter. But, thank you again, Dr. Jacobson. Really appreciate that. And with that, I'd love to introduce Jane Ward, who's the HIV Surveillance Coordinator for Ventura County Health Department. And Jane, if you could, I'm going to share the screen, but if you want to briefly introduce yourself, that would be wonderful.
I'm Jane Ward with Ventura County Public Health HIV program. I've been trained in depth by Lynn Bartosh, who was my mentor, and I was her backup for 5 years before she sadly decided to retire this year. And I've been with the program for 10 years. I started out as a HIV test counselor and moved into this position gradually, and then eventually, as Lynn retired, I took over for her.
Great. And so we're going to go through your slide deck, and so just let me know when to move on to the next slide.
Sure. Next. Next slide. So the Ventura County HIV rate is 3.3 per 100,000 people. It's lower than the state average. A lot of people who do live here do seek treatment and care in LA County. In 2021, there were an estimated 1,500 people living with HIV in Ventura, and of course, this is probably an average kind of amount, but at least 75% are men, and then Hispanic or Latinx people are 64%, and then 30% white. The age group is, with the highest cases, is 30 to 39, followed by 20 to 24, or 20 to 30, or 29, according to our latest surveillance report. Next. So we did have considerations for and possibly some barriers. One was a buy-in from all stakeholders, including the hospital administration, medical staff, and the community partners. And Dr. Jacobson did a beautiful job of coaching us to get what we needed to get the program started relatively smoothly. And Lynn was a huge part of the beginning of the program in 2015. We started April 15th of 2015, and the process of training the staff in the ED involved some back and forth and a lot of frequently asked questions, but eventually we were able to get everybody on board, and then we were able to be lucky enough to have somebody evaluate the numbers and prove almost immediately that this program was not only worthwhile but really going to improve the health of people in our community. Next. So we did find our champion, and Dr. Scott Spire was the original head of the ED, and the triage mechanism for the emergency department, when a concern about how are you going to implement the opt-out, or does it take more time to triage somebody, it really doesn't. It's probably one more sentence or half of a sentence when you're doing an intake, getting them to understand that in addition to a chem panel and whatever else you're going to be running for them, just ask about the say we're also going to run an HIV screen. The pop-up question we use EMR that we were able to get that pop-up question as a reminder. We would provide a written pamphlet explaining what the test was and the services available. The lab surveillance coordinator was able to expedite the screenings as they came through, determine insurance billing, which is part of any hospital visit. Usually insurance pays for these services, and then follow up if the patient is positive. We already had in place a system of instantaneously starting to link a patient to care, and this is something that Lynn Bartosh had also started. She's been in the program for over 20 years and highly successful in linking new patients to care and getting them on medicines immediately. That was one of the concerns that the ED had expressed, is who's going to follow up with these patients? Well, naturally we were part of the equation, and definitely the answer was the HIV program, and we were already part of the linkage to care, and actually with other patients in doctor's offices or other clinics, when a positive would come up, we would be present at the time of disclosure and link to care right then and there. We'd actually get labs ordered and an appointment for this patient while we were seeing them in their PCP or whatever clinic they were in. So they walked out of the room, out of the appointment, knowing that there was a plan and that they had a network of support, and that if they had any questions, we were available with caring, culturally sensitive services and support. Next. So as Dr. Jacobson had indicated, having it written out so that there was a visual as to how things happen, here is the information tree. So, in the top, initiated, we use Cerner. So during the triage or the intake, inform the patient that there will be a test provided, or a screen provided, along with what other bloods were going to be drawn. If the patient opts out, it's of course checked off that the provider informed, and the patient declined to have that screening. If the patient does not opt out, we let the provider know, and then the HIV, the 1,2 ABAG drawn and sent to the public health lab, which is how we use the public health lab. A negative result would be the follow-up with the provider. They could just give the negative results. If there was a positive confirmed, then the results would be placed in the chart. The results were sent to the public health HIV surveillance coordinator, and then we would set up an appointment and reach out to the patient to discuss previous labs, and then in an appropriate setting, we would disclose the results with their PCP or their provider. If not, we would meet with them, and then we would link them to care instantaneously and explain what services were available for them, whether they were, case management services, mental health services, but definitely getting them into specialist care and on medicines within 24 to 72 hours of diagnosis. Next. So we have roughly 1,200 tests monthly, and this was at St. John's Regional, was the second hospital. They have campuses in Oxnard and Camarillo. Ventura County Medical Center has 2 campuses, one in Ventura, one in Santa Paula. So we were working out of approximately 4 EDs. St. John's did join later in the game. I think it was 2017 or 2018 that they joined. But we've found quite a few people who did not know that they were HIV positive out of the St. John's campuses, and we were able to link them to care as well. So we do have 7 or 8 hospitals in our county, and we're still working on the other hospitals. But just imagine a scene where all the hospitals in the county are on this program, how many more people we can help and reduce infection rates in the community. Next, please. So I know Lynn's on. If Lynn, if you wanted to talk about some of the numbers and the loss to follow-up and linkage to care.
Hi, everyone. Yeah, Jane, great job. This graph I put together, part of what Dr. Jacobson had commented on is sort of the continuum. Once you set it up, you're not really finished. We thought it was important that each year we come back and give the ED, give the champion the data. So that was very confirming to them that what they were doing was making an impact. And it wasn't only people with a new diagnosis, but a lot of times you have people that are lost to follow-up, and they'd come back in through the ED. So on this graph, you can see the number of new diagnoses each year, and you can see the new linkage to care, which we were fortunate enough in the system we already had set up. It worked perfectly. It was an easy transition, and we're right there with the patient, as Jane mentioned. So we're at like 98% in linkage to care. And the loss to follow-up is a little bit different because that's usually a little bit of a transient population. But once we would get that result and realize, oh, this is somebody we already had reported, but they've fallen out to care, then we would attempt to contact that patient as well, or do an actual visit and try to get that patient linked back into care. So this is some of the data and the total number tested down at the bottom. And you can see usually over 12,000, and 2021 was just for 6 months. Do you want to go next? And then this is some of the data I also got from the hospital themselves, so we could kind of look at, who was Ventura County seeing. And Dr. Jacobson explained that a little bit, and I was a little surprised in terms of the number of tests done, that in terms of the Caucasian population, and then Latinx and Mexican migrant, we have a lot of migrant workers here in our population with Oxnard and Santa Paula, Simi Valley, who rarely actually even seek care. And usually the ED is the first place they go. And we have a very small African-American population here. However, when you look at the number that are positive in relationship to the population, they actually have a high prevalence rate. Next. And again, just looking at gender so people get an idea of female, male, looking at the total number of tests. Close enough. 5,500 female, 6,800 male. I think the females, the males tended to use the ED more than have a primary physician, especially in the different populations. Next. There you go, Jeannie.
So another benefit of screening like we do in the ED as an opt-out is it helps remove any stigma or any other things that would preclude people from maybe getting screened. Funny enough, we do pull people from all walks of life, all ethnicities, and I think that this is a really good way to do kind of a blanket coverage and really kind of get everybody who might not normally be seen in a healthcare setting, as Dr. Jacobson had mentioned before. And I think that it's an awesome way to expand on trying to get people into care for definitely HIV, but for other things. So if we could use the HIV opt-out screening as kind of a template for other things, that'd be great, because as you can see, we've had huge success with it, and we've improved the lives and health of many people, and the long-term outcomes have really shown the success of this program, especially in Ventura County.
One quick thing I'll add, in terms of the process at VCMC, they have progressed to the point where we were talking about the doctors having so many pop-ups. It gets a little overwhelming. At VCMC now, they switched the process to the triage nurses that are the very front line, are the ones that the pop-up comes to them first. So they get to ask the question before it ever goes to the doctor. And then whether they say yes or no, they're handed the pamphlet there. So they understand it before they even get taken back. And that takes a little pressure off the doctor. He knows whether it's a yes or no when he gets to seeing the patient.
And everyone, that brings us to our question and answer section for our panel. So Lynn, Jane, or Dr. Jacobson, we invite you as we sift through these questions to chime in.
All right, everyone, thank you can we give Dr. Jacobson, Jane, and Lynn a round of applause for all of their great work? So the first question is for you, Dr. Jacobson and Jane. Can you speak to the legal concerns that have been raised by EDs about opt-out testing? California law requires verbal consent for HIV testing.
Actually, California's law supports opt-out testing. So one of the things we did at the state this past year was come out with a Dear Colleague letter that brought to emergency rooms' attention the fact that California law does in fact support opt-out emergency department testing. I think the legal issues tend to be more of a concern of administration than a reality of the programs. I think administration and hospitals are often really worried that legal issues are going to surface, but the reality of them surfacing within the programs are very rare. You know, in the 12 years that I've done this, I think I've heard of 3, and none of them had to do with somebody getting a positive test. It had to do with someone getting a false positive test, which I will also add are rare. About 1 in every 2,000 tests are false positive with the antigen antibody test. And usually you're able to explain that to individuals, and they're, I've never seen them move towards an actual lawsuit, but they just come up at, as concerns that as long as you address them and explain that risk happens, but it's rare, individuals are usually, you know, understand it. I don't know, Lynn or Jane, you guys might know, have other experiences you might want to share.
I think the only time we had a question was someone stated they hadn't been asked. But in going back in the chart, indeed they had. They were, I mean, I don't want to say what they came in for, but it was easily something that might not have been comprehended at the time. So that was cleared up. We've had a couple false positives, and basically, you know, I could look at the risk assessment, and when they got linked to care, they were retested again, and we could go from there and figure out if that was a true false positive. And then we worked with those individuals and educated them, and you know, there's not much you can do about that with the lab. It, you know, they do come up once in a while, but it was never a problem, and trust me, they were very relieved that it was a false positive.
So we are close to wrapping up, just 2 more minutes. A question for you, Jane. Can you share what screen test you use and how did you handle results?
Lynn?
HIV 1,2 ABAG, and then it needed to be confirmed by the HIV 1, which is the legal, I don't want to say legal, but that is the test that's used in California. I saw a question where, what do you do with the indeterminates? The indeterminates, I would get those results as well. I would contact the lab to see if they had any other blood, plasma, etc. left over, and we would send that off for a viral load to be able to confirm whether that was a positive or negative test.
Okay. Thank you. And just 2 more questions, and we will wrap up in just 2 minutes. Dr. Jacobson, can you repeat the percentage of newly diagnosed individuals with acute HIV infection in the EDs?
Yeah, and this is actually published data for 9 emergency rooms across the US. Excuse me, and it was 14.5% of newly diagnosed individuals, sorry, something in my throat, that had acute HIV at the time of their diagnosis.
Awesome. The next question for everyone, did you monitor lab results turnaround time, including HIV tests?
We didn't specifically monitor it. Our turnaround time, the labs from our county hospital go to our county public health lab. And we work with them on a, as Jane, on a daily basis. And it was probably, I'd say 2 to 4 days turnaround.
Okay. Well, thank you all. In the interest of time, we want to just say thank you. We are putting into the chat now a link for the evaluation for this webinar. We just thank you all for your participation. We had a lot of people show up today. We had a great time. The link for the evaluation is in the chat. It's from SurveyMonkey. I'm going to copy it in one more time. But please, 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 everyone, fill out the evaluation. Thank you, Azul, for your great job with this. Thank you, Dr. Jacobson. Thank you, Lynn. Thank you, Jane. Thank you, everyone. Have a great day. Yes, we will be sending out the recording to this, just for everyone who has who attended today. And we are so happy that you could make us a part of your day. Have a great day and drink some water.
Thank you, everyone.